Welcome back. I'm Jason Andrade from Vancouver, Canada. For session 10, the focus will be on expanding indications, PVI plus procedure with pulse field ablation, and ICE guidance. To lead us through this, we have a case presentation from Dr. Luigi Di Biase from Montefiore Health System, Albert Einstein College of Medicine in New York. Welcome to Luigi. We also have on our panel Moussa Mansour from Boston and Moeen Saleem from Naperville. Without delay, let's hand it over to Luigi to take us through the presentation.
Hello, hello, Jason and everybody. So I will present a case of a PFA with the varipulse catheter, and we will see, what is my workflow and some important aspect of the utilization of this catheter beyond PVI. Next slide, please. These are my disclosure. And next slide, please. 1 second. I have to minimize. Okay, good. Okay, these are my disclosure. Next slide. So the first thing that I like to do is a workflow where I go in and based on this paper that we utilize, we helped the company to develop, where before the automatic algorithm was there, we basically took a segment of the left atrium through the eyes. We told the algorithm of AI what was it. We make a comparison with the CT scan, and we finally submit the paper that got an approval. And this was the first live video that we sent everywhere. And I love it because while I'm understanding the anatomy of the patient, you have a shell of the left atrium. And this workflow I was already using with the RF, but now with PF becomes extremely good because ICE and I go transeptal, and based on that shelf, I can basically start the ablation as long as I have given a full amount of heparin. And this is a paper that is almost impressed on Europace. It's under second review, where we did this workflow with QDOT. As you can see, 2 core here for efficacy, where we compare a patient that underwent shell as done by the ICE, transeptal and ablation versus transeptal FEM with a pentarray or an octarray, and then ablation. You can see no difference in the outcome, but improvement in the workflow and the efficiency of the procedure. At that time, people really don't like this much. I would say the company didn't like it because we were using less of their product, but at the end, it turned out to be a great workflow. And when we do it now, we do with varipulse, we do the same after transeptal. We start assessing the contact, and you can see here all the 10 electrodes are in the sheet, and then we assess contact. Once we have contact, we can see the contact through the TPI. And can you advance, please, to the video? It should start the video. You can see the way we assess the contact is after the training that every dipole will have will have a baseline impedance. That baseline impedance is in average 140, 150, where the mouse is. And you can see all the bar are above that level. So I know I have contact through the TPI, and that's something extremely important. If you don't like TPI or you want to double check, then you can also use ultrasound if that is what you prefer. But I think this bar here will give you a good idea. And I always like to have windows here showing to me if the electrodes are touching or not by tilting the view and not having it playing in different angles so that I can see what's going on into the catheter. Again, if you don't really like the TPI, or you want to double check, then you have integration with ultrasound that will not only give you the shell, but can show you a nice image of the contact. This is the crystal ice with a higher number of crystals that allow for a better visualization. So the usual open question with this calendar is, can you do PVI? Can you do SVC and posterior wall? Can you do CTI? And can you do a mitral isthmus line? Well, I would like to explain that in my current workflow, I always do PVI, posterior wall, and SVC. I am not a fan of PFA with single shot for CTI line. And I think on mitral isthmus, we need the RF because there's too much reconnection. There's some data that we publish with the Farapols. I think with this catheter is not that different. I think for a good isthmus line, you need a hybrid catheter and you need some RF. This is an example here where the full posterior wall has been ablated, and I like to utilize always the middle of the posterior wall to even do the antrum of the vein. I like to kind of do a sort of Olympic Games where I put the catheter here and I do 1 and 2 in the middle, and then I rotate clockwise or counterclockwise to complete the antrum of the vein after I've done the initial 2 ablation per ostium. And as you can see, beyond PVI, with the full posterior wall here ablated very well. And when you are in location where you don't have a good contact, what you can do is deselect the electrodes that have no contact in order to have a more prominent lesion. And this is at the end, the PVI, the posterior wall, and you can see here the anteroseptum that we always have reported as an arrhythmogenic area. And so, first example of going beyond PVI is PVI posterior wall. I always do SVC, and I do the SVC eyes guided in order to avoid sinus node dysfunction. We utilize the pulmonary artery here in the eyes view, and we never go below this level. There is actually no risk of phrenic nerve. I've done almost 300 cases with no risk. And I like to see the bar that give me contact here in the SVC. And to further explain how eyes guided means, this is the PI, pulmonary artery, and you can see never go below of this. And this level is very safe to isolate the SVC without impacting the sinus node. And I have here again the right superior PV, the pulmonary artery, and at this level I think is very safe to isolate the SVC. And this is the full video with all the parameters in place. So we see the posterior wall, we saw the SVC, but can you do some difficult flutter with this catheter? I show you a quick example here. The patient with the third redo, previous CTI, PVI, and posterior wall and SVC isolation, and all prior ablation done with radiofrequency energy. So we start and we put an octa-array here, and you can see the full cycle length here is into the LAT histograms. I like, and some of these software are complicated, but at the end, if you have a bar in all of the LAT histograms, it means you are in the right chamber. And then I reviewed here. You can see the voltage and the flutter activation. And here you really see a propagation map. And clearly you see there's a channel here. It's at the level of the esophagus. And this is why 3 AFib ablation probably failed to completely cover that channel over the esophagus. We decided we cannot go RF, it's esophagus. So we went with the variables. This is, the training that you have to do for all electrodes. It's the equivalent of 0 the catheter. Before we only had to 0 1 the tip of the catheter. Now we have to 0 the full circle. And this cone was created to guide the movement inside an area where there is no contact with the anterior or the posterior wall. This is the mapping with the variables. You can see it's not as accurate because of the 8 millimeter electrode sides, but at the end, you can see that is a very good map here with the mesodiastole. The octa-ray is still better, but actually very good. And at this point, we put the variables at the level of the lesion we want to create. And we go on, and with one application, sinus rhythm here. And you can see here again how we move the catheter, and sometimes closing the loop, opening the loop can give you more contact, less contact, visualized again on this bar and on the ultrasound. Again, another example here, this part of the catheter is going on an area of scar. So we deselect. When you deselect the area, they become gray, and all the yellow one are the ones that are going to deliver a lesion in this area. This is the pre and post voltage maps proving now full isolation of the channel that had reconnected despite 3 ablation. Another example here, another redo. This patient had PVI, posterior wall, and SVC in the index procedure, did well for a lot of time, came back with a flutter. Everything was isolated, but the anterior wall was the only area with the signals. Again, we place the variables in the anterior wall. You can see here on the ice. This is again the crystal, proving the integration with the intracardiac echo. We see good contact there. And by ablating that area, we got termination on the flutter. And now the patient is in sinus rhythm. You can see actually how the ice has an area of echogenicity that give us information of voltage, because this is the area that were previously burned at the prior RF ablation in the posterior wall, and now we had to go anteriorly. And again, this is really the area of scar. So I really hope that the integration with the imaging will give us not only anatomical shell, but also some substrate information. And I think we are already in a good level now. I hope that with more AI algorithm, we can improve the implementation between ICE and our mapping systems. So in conclusion, I show you example of using PFA beyond PVI with ICE integration, example of SEC isolation, posterior wall isolation, anterior wall isolation, and I hope you like it, and we can go to the discussion. Thank you very much for your attention.
Luigi, for such a wonderful presentation. To the audience, please remember these sessions are live, so feel free to put questions into the chat, and we'll try and address them as the discussion goes on for the next 15 minutes or so. I guess the first question I would have for you, Luigi, is in the context of having a catheter that allows you to assess contact directly, do you feel that the ICE, or how much incremental benefit is there with ICE for assessing lesion delivery and contact assessment?
I think the TPI indicator is pretty good, especially if you use that bar level that I showed you. On the other hand, the ICE integration, I think, is key, because you can have, I would say, very comfortable transeptal with the eyes, no matter how difficult is the anatomy. You can monitor complication, and you can have integration, because I didn't acquire the shell. The shell that was done in my cases was done with the eyes. The eyes allow you to eliminate or reduce fluoroscopy from the beginning of the case, from the transeptal. So I think eyes is extremely important, can improve the workflow. My workflow is with the eyes and transeptal. Now, when you have to map a very difficult arrhythmia, can you do directly with this catheter, or do you have to use an octa-ray, penta-ray? I show a case where I had both maps. We know the limitation of using at a catheter with a big size electrode, which is not as accurate as an octa-ray. But in this case, my map show very well that the variables could give you a beautiful understanding of the activation. And so the whole case could have been done with ICE and variables.
Luigi, so it's very nice case that you showed. And you showed us a couple of examples where you ablated outside the pulmonary vein and the posterior wall. Can you please elaborate a little bit on where else do you use this catheter for in the atrium? Like, for example, other than the posterior wall and the pulmonary vein, do you use it for the mitral isthmus? Do you use it for CTI? Or you think other tools you will pull a standard catheter, focal catheter to ablate these areas?
Yeah, I think in general for CTI, every time we do that with PFA, we are challenging our patient because we know we need to use nitroglycerin. Some technology are more amenable than others. Some shape of catheter are more amenable than others. But I think for CTI, RF is the best. So for me, a hybrid catheter is the solution. And if you don't have a hybrid catheter, opening an RF catheter is the solution to go hybrid. Now, in this specific case, when I do varipulse and it's a Johnson & Johnson procedure, until they have a hybrid solution, I open an RF catheter. Is within the scope of the company to have very good RF catheter for years. So I think it's a matter of having a good deal that when you need to open an RF catheter, you can open it without increasing the cost of the case. For mitral isthmus, I think PFA can do it. All technology can do it. Varipulse can do it. I like to do a posterior line rather than an anterior line. Both lines, though, reconnect. And they reconnect because I think the current waveform is not good enough. So we need to retouch with RF no matter what. And I think with all technology, unless you're using a technology with dual energy. So again, if I had to do a mitral isthmus line with this catheter, I do it. And I do it to facilitate my RF job. So what I do, I put the varipulse in the mitral, in the posterior line. I do 3-4 application with PF. I can get even terminational block, but I know I cannot stop it there. So I open an RF, I go into coronary sinus, and I complete the job with RF from the coronary sinus. And this is why I like to use the posterior line.
So actually, that makes a good point. So there's a paper that was just published within the year that showed that if you stack PF onto RF, you can actually get further lesion extension and deeper into the tissue. So you can have an additive effect when you have dual energy catheters as opposed to relying on a single energy. There was a question in the chat that builds off what was just stated. So Luigi, beyond PVI, do you have confidence with the current Varipulse system that it can do all of your extra pulmonary vein triggers, posterior wall, SVC? You feel comfortable with all of that nowadays?
I am very confident. I've done more than myself. I've done about 200 cases right now. I've done SVC in probably 180 of my cases, and if not, I would say 80% of the cases. SVC, absolutely yes. Posterior wall, absolutely yes. And I would say even down to the coronary sinus, not only the part contained within the pulmonary veins. What is key is to understand the stability of the catheter, the maneuverability of the catheter. This catheter is not easy to use as other catheters. So you need to practice and understand. My recommendation is to use the posterior wall as the base of your movement and find where the catheter sits nicely into the posterior wall. When you have that, use the posterior wall as your base. And so when you have that with good contact, you undeflect the sheet to go up, you deflect the sheet to go down, and then you counterclock to go to the right veins, undeflect and go down, then go back to the home, and then counter for the left vein, undeflect and go down. So it's at the end is as I said, it's an Olympic Games of 9 application. And I like this also to kind of take care of the antrum rather than going to the vein, do the ostium, and then pull out and do the antrum, because in that position you may not have good contact, or not in all the anatomy. While if you use the posterior wall as the base of the maneuvers, you will always have good con. Now, the comfort zone, as I like to call, is not always in the middle of the posterior wall because depend from anatomy, depend from the ridge, depend on how much the ascending aorta is dilated. So every patient will have a different zone where the catheter sit properly, and use a lot the variation of the loop. Open the loop, close the loop. Little movement of the loop will allow better contact. So you need to kind of practice. It's a catheter that require, I would say, 15 cases before you get familiar with the movement because it's a little stiff. But once you do that, you get all the advantage of integration, eyes, good mapping, and many more.
Luigi, would you say
Very nice.
that for the posterior wall, that even though with TPI calibration, we can visualize the spheres, but I found that ice is absolutely essential to confirm posterior wall contact in the configurations that you've described. And I like the way that you're describing, the place to find the home base on the posterior wall, because I found part of my learning curve with this catheter is that it's primarily a sheath-driven procedure with some nuanced, subtle movements of adjusting the loop or the curve, but it's primarily a sheath-driven movement. Is that what your experience has been as well?
Yes, it's a 90% sheet maneuverability, 100%. Transeptal is very important because as a single shot, we don't go as posterior as with the point by point. So you want to go anterior, but you don't want to go super anterior. You want to kind of see the appendage and a little bit of the veins when you use this. Yes, it's a sheet only. And yes, I agree. Ice is beneficial to assess contact. The good thing is that between the cloud and the bars and the ice, you don't need to put the ice in the left atrium to assess contact. The right side is good enough. And that allow you to save some time and to not have to maneuver the ice in the left atrium. And also, we are not discussing enough, but building, going transeptal and start ablating with the 3D shell already there that is pretty solid is an amazing workflow, which I have trouble to go back to what I was doing before.
Have you had any concerns with vagal responses with this catheter? Like, did you alter your workflow and start on the right veins, or do you find that it's not
So,
as problematic as?
what I noticed is that the vagal response of this catheter is inferior than others. There is no much of vagal response. With the competitive technology, I actually prophylactically give glyco after going transeptal. I give 0.3. With this catheter, I give nothing. And out of, again, probably 300 cases, I've seen a severe effect requiring pacing one time only or never. So there is a different response to that. If you guys have had a different experience, let me know, but I really haven't.
I agree with you. I mean, that's been our experience, and it's the same, I think, to the point that you raised before. I mean, most of the manipulation for this catheter, and I think most of the PFA systems, as well as the old single shot devices like the cryo balloon, was really in the sheath. And so people who transition from point by point, they might have the feeling of what it's like to manipulate a lasso coming from a point by point. And this is not that. This is different. This is something that you have to get used to. But once you get used to it, you understand the motion, how it's going to translate, and how you can get a good quality lesion out of it.
Do you do anything
think, most of the-
for your post map?
Yeah, that's actually a very good question. When you do a post map with this catheter, it's again challenging because the size of the electrodes will capture a lot of far field from the anterior wall, far field from the appendage, far field from the right atrium. So it's a kind of tricky to discriminate what is a real signal and what is far field. But if you train your eyes and you spend some time, you find out that most of the time, signal that look like reconnection are not, and they are far field. I would say the catheter behave very similarly to the other PFA. After the 1 second application, the signal are gone. And if you see a signal, before you say it's reconnected, make sure that it's not a far field. And it's something that needs to be done because it happens very frequently. It's an 8 millimeter electrode side, so it's very easy to get far field.
Luigi, there were some cases where I tried to pace from the posterior wall after ablations, and if it's captured, I do some more ablations. Have you tried to do that at all?
Yes. There are some cases where that has happened because I do. Another advantage, you can go back to do EP here because we do exit block in all the veins by pacing. And then, sometimes I try to test the posterior wall with capturing. I still struggle to understand if I'm capturing a connected posterior wall versus a far field from the anterior wall. I think time will say the truth, meaning I don't have one full year follow-up in the majority of these patients. And I think once we start doing the remap of the redo of this catheter, we'll understand. Right now, I tend not to do extra application. If I think all the lesion I give in the posterior wall were given with good contact, I ignore the capture right now.
Yeah, it's I do it. So it's relatively kind of quick, easy to do. Use the same catheter, plug it. If you capture, just give it maybe a couple of more applications. I don't know. I found it useful, but I agree with you that we may need more time to understand this aspect.
All right. Well, maybe this is a good time to draw the session to a close. Our thanks to Luigi for such a great presentation and our panel for the great discussion. This is the end of the day for me, but Rhythm Interventions Online will continue. The next session will be coming up in just a moment.